Good morning, everybody. We're just waiting for everybody to join the webinar this morning. So in the meantime, please have a look at these housekeeping instructions on the screen, and we'll be with you shortly. Morning, everybody, and thanks for joining us this morning. We're just going to give it a minute or two longer for everybody to join and get set up. In the meantime, please do have a look at these joining instructions. In particular, set your screen to speaker view, we would recommend, so that you can see who's talking. And please note that we have a busy schedule today, so we won't have time for verbal questions, but we're really keen to get your questions and comments in as we go through today. So please use the chat function and post any comments and questions in there. We'll start in a minute or two. Well, good morning, everybody. We will make a start. I think most people have managed to join us now. Welcome to this Live Longer Better event this morning. Thank you for joining us. My name is Lee Mason. I've been asked to chair the event today. We've got a great program lined up with lots of fantastic speakers, and I hope you're ready and sitting comfortably. I've just dried out from my dog walk this morning and thawed out because it was pretty cold out there. Fed the animals, got the kids home, ready for homeschooling. I'm sure you've got many similar issues where you are today. So thanks very much for finding the time for joining us today. And I hope you get a lot out of the event. We've had an amazing response to the event, advertised at short notice, but over 250 people joining us today. 55, I think it is, from Age UK's across the country. 43 all active partnerships represented here today. 74 colleagues from local authorities, as well as colleagues from housing trusts, care homes, leisure trusts, local and national charities and agencies. So a really vibrant group of people who are key to taking this agenda forward, and we're really pleased to have you with us today. I think that really shows how topical and important this issue is. And therefore we will record the event today in order that you and we can share the proceedings with other people. So please do help us to cascade the messages that we're convening today. Given the diversity of the group, we've been asked to just set the scene a little bit with a little bit of context, and in particular for those that aren't familiar with active partnerships, to say a few words about active partnerships and where this work has come from. There are 43 active partnerships across England, and our mission, our vision is to make active lifestyles a social norm for everybody. Our mission is to tackle the challenge of inactivity, growing levels of inactivity across the country. Fundamentally, we work in partnership, and today's event is a great example of that, something I'll return to in a second. And we're really committed to using the power of sport and physical activity to transform people's lives. Again, a theme we'll return to today. We cover the whole of England, only England. And on this map on the right, you'll see marked out as Oxfordshire, and very much this event and this piece of work, this community of practice, it's emanating from some of your colleagues at Active Oxfordshire, and quite typical of the way we work in terms of identifying some energy, some good practice, sharing that with other people, and then engaging with others across the country as we're doing today. This is our core purpose, and I think it's really relevant to today. So we're really focused these days within active partnerships about trying to adopt a collaborative, wholesome approach to create the conditions to enable everybody to be active in their everyday, to make movement, to build movement back into and supporting our workforce, and we'll hear elements of that today too. Creating new and interesting behaviour change interventions, and some well, and critically sharing the learning as we go. And of course, today's event is all about that. Live longer, better. Other colleagues will talk more about this as we go through today, but essentially we are building and developing a community of practice and learning. And it's emanated out of Active Oxfordshire. It started with a number of active partnerships, but we really want to build a movement across the country to affect the change that we want to take, to affect. The need has never been greater. The timing has never been more important in terms of COVID-19 and its effect on our communities. And the programme involves system design and system change, creating a cultural revolution and building networks across the country. And again, it's great to have you with us. This slide just talks to the community of practice and the kind of people that are involved, a number of active partnerships, a number of other partners, and a national steering group involving all of those agencies you can see on the screen driving this work forwards. I think it's in just a few short weeks, we've really got a strong coalition of key partners, which gives us confidence we can really make a difference. So on to today's session, and you've hopefully seen the programme for today. The first session really focuses on the need. Why now? Why are we tackling this? What are the issues within older people that we are trying to address? Then Simure will come in terms of the evidence base and some of the science and the ideas around Live Longer Better. And then we've got some local examples to share with you of people that are making progress with this area of work. So without further ado, I'm going to stop sharing my screen. I'm going to hand over to Jess, who hopefully is with us now and will take us into the first session. Are you there, Jess?
Yes. Hi, thanks, Lee. I will just start sharing my slides. So hopefully everyone can see that. So my name is Jess Kuna. I am the Senior Program Manager for Healthy Aging at the Center for Aging Better. And I'm here today to talk about the state of aging in 2020 based off of our flagship report that we launched at the end of last year. So I'm just going to briefly talk about who the Center for Aging Better is in case you haven't heard of us. So we've been around for about 6 years now. We are an independent charitable foundation. We started when the former chair of our board, Lord Filkin, launched an inquiry in the House of Lords into whether or not the UK is ready for aging, and found that the answer is no. As a country, we are not ready for an aging population. And so he went on to secure an endowment from the National Lottery Community Fund, that's how we're funded, and set up our organization. And we are a part of the network of What Works organizations that promote the better use of evidence in policy and practice. This is a network of about 9 organizations. We're all independent of government, and we all work in slightly different ways. Most of you are probably familiar with NICE. NICE is the oldest What Works center, and then there's a variety of other ones on policing, early intervention, well-being, things like that. And so we all work slightly differently, but we all promote the better use of evidence in policy and practice. And our vision as an organization is a society where everyone can enjoy their later life. And also just to note that the Center for Aging Better is focused generally on people in mid to later life. So roughly the 50 to 70 age group, because we believe there's still a significant opportunity to change people's trajectories before they reach that later life stage, which is why as an organization, we're specifically focused on that age. So our priorities as an organization, we have 4 main priorities focused around work, housing, communities, and healthy aging. And I'm specifically going to talk about healthy aging today, but this Venn diagram basically just shows around the outside, you can see our 4 priority areas and how they overlap and how they all essentially contribute to what we want to achieve, which is a society where everyone can enjoy their later life. So I'm going to talk about our flagship report, State of Aging 2020. We launched this, I think, in November last year. And I'd really encourage you to go. I'll post a link at the end to the entire report, because it's really a huge trove of data and information. And the report is broken up by those 4 areas: work, housing, communities, and health. But I'm specifically going to talk about the health bit of it. So really the headline message from our report is that we're all living longer, but we're not necessarily spending those extra years in good health. And also we've seen that progress on life expectancy is stalling. So this first slide shows you what disability-free life expectancy is in England at birth for men and women. As an organization, we focused on disability-free life expectancy, which I'm going to explain briefly here. When we talk about disability-free life expectancy, the way the ONS asks about disability-free life expectancy is they ask if somebody has a long-standing health condition, and if the answer is yes, then the next question is, does that health condition limit your daily activities in any way? And if the answer is yes, then it's basically considered a disability or disabling health condition. So we're not talking about, I mean, as a very basic example, for example, I'm short-sighted. I would not be able to do my daily activities without glasses or contact lenses, but I do wear them, and so it doesn't impact me. So that's not a disabling health condition. It's not something I consider to be a disability. So that's what we're talking about when we talk about healthy aging. We're not just talking about physical and mental health. That is a key part of it, but we're also talking about the environment and how that supports people to continue to be able to do their daily activities, even if they've experienced a decline in physical or mental health. And so here you can see that women and men are spending, so women are spending the final quarter of their lives in poor health, and men are spending almost the last fifth of their final life in poor health. And then this next slide is specifically looking at for people once at age 65. So for men and women at age 65, they're roughly both spending nearly half of their remaining life in poor health or living with a disabling health condition. So this slide is really to show the trend of what we're seeing here. So the blue lines are life expectancy. So you can see that it has been on the rise, or generally the trend has been, it is still rising, but the progress is stalling. But on the amount of time we're spending in good health, disability-free life expectancy, that is falling, particularly for women. You can see this dip happening at birth, and overall, just for at 65. We're actually starting to see that bigger gap between disability-free life expectancy and life expectancy. And that's really borne out in this next slide as well. So again, the overall trend at birth and at 65. This is the proportion. This graph represents the proportion of time of our life spent with a disability, and the proportion of time we're all spending with a disability or a disabling health condition as we grow older is actually slightly rising, and that's something that we should all be worrying about and thinking about how we can address, because it has all kinds of implications for whether or not we can continue to stay and work, whether or not we're able to live in our own homes independently without needing care, and our own need for health and social care is obviously also affected by that. And so those figures that I just showed you are obviously averages. This slide shows you the really stark differences between the poorest and richest areas in the country. So people from the wealthiest areas are spending a much longer proportion of their lives free from disabling health conditions compared to the poorest. So really stark contrasts that we're seeing across the country. And it's not just by area, there's also quite a big north-south divide. So people in the south of England are able to have longer disability-free life expectancy than people who are living in the north. Now, when we look at what conditions are causing, what are the biggest disabling conditions, what are the biggest causes of disability in later life, this graph is a breakdown of that. So we have the blue bar, which is showing what the biggest disabling conditions are from ages 50 to 69, and then how that changes from 70 and over. And for both of those age groups, musculoskeletal disorders are the single biggest contributor, so back pain, neck pain, arthritis, things like that. And then you can see the breakdown. So it's interesting as you go down the list, sense organ diseases, so things like hearing and vision impairment increase dramatically after the age of 70. So these are not necessarily conditions that are causing early death, but these are conditions that are significantly affecting our ability to be able to do our daily activities and continue to be able to do those things that we value. So this next slide also shows the inequalities between conditions that people are experiencing. So the poorest women are much more likely to be suffering from depression than the wealthiest. There's almost they're almost 4 times more likely. And you can see this pattern plays out across conditions. So whether or not that's for depression or arthritis or respiratory illnesses, you can see that women from the lowest quintile have much higher rates of these conditions than people from the highest wealth quintile. And it's this next slide. So this is for men. It's very similar for men. For men, the difference, particularly for depression, is 5-fold between the most well off and the least well off. So really stark inequalities, both in the amount of time that we are spending free from disabling health conditions, and also when those what health conditions are developing. So the next few slides, I'm going to specifically talk about health behaviors, so risk factors for poor health and disabling health conditions in later life. So these first slides are about physical activity. So we know that the older we get, the more likely we are to be inactive. So inactive is that dark purple bar at the bottom. So you can see that levels of inactivity really pick up from about age 50. So when I talk about inactivity, I think many people will be familiar with this. We are talking about people who are doing 30 minutes or less of physical activity per week. Those individuals are classified as inactive, and that really starts to pick up from your 50s, and then there's a really big increase from your 70s onwards. And that's something that the Center for Aging Better is particularly interested in understanding what can we do to get more people to be active as they age, and also is there anything we can do to stop them from falling into that maybe active or fairly active category into the inactive category. There's also quite significant differences in who is active and who is inactive. So again, big inequalities in terms of wealth. People in the most deprived areas have, for the ages of 55 to 74, are much more likely to be inactive than people from less deprived areas. And there's a whole host of reasons for that. Things like access to green spaces, things like access to all sorts of different types of activities, pressures of work, poverty, health conditions are much more likely if you're from a poor area, and health conditions can play a really big part in whether or not somebody feels that they're able to be active or not. And similarly, just another slide breaking down levels of physical ethnicity, activity by ethnicity. We see differences by different ethnic groups. So, and also again, there's big regional differences. So people in Cumbria and North Yorkshire are most likely to be active in midlife, and so the pale areas, you can see the contrast, that there's quite a significant regional divide between, as we get older, who is still able to be active in which areas. So this next slide is about obesity and overweight. So levels of people living with obesity or overweight, they peak in midlife. So they generally increase across the life course. But again, when we're talking about that kind of 50 to 70 age group, we can see a peak both for men and women in that kind of mid to later life stage. And for smoking, so overall smoking levels fall for as people grow older, but it is interesting that for men in particular, 1/5 of men are still smoking in their 50s. And then this final slide is on harmful levels of alcohol consumption. So again, we are seeing much higher levels of harmful alcohol consumption in that midlife stage. And we don't fully know why that is, if there is actually an increase happening or whether or not it's people as they age, they're continuing their drinking habits as they grow older. So we do know that there has been a drop in drinking levels amongst younger adults. But for people as they're moving into those older age cohorts, it seems to be that it could be that they're carrying their drinking habits with them. And so that's why there is this quite significant peak in mid to later life that is quite concerning, because I think a lot of people when they think of harmful levels of drinking, it's often like harmful levels of binge drinking amongst younger adults. That midlife cohort doesn't always get the same level of attention when it comes to risk from alcohol. And so that is basically a quick summary of the health section of our State of Aging report. So again, our State of Aging report has all this data and more on health, communities, homes, and fulfilling work. And this is the link. And so if you are looking for any more stats, our team have done a really tremendous job in pulling this all together. And if you go onto the website, it's actually very interactive. So you can click on the diagrams, you can click on the source data and get the numbers as well. And so we just hope that this is a really handy tool for anyone who wants to get a comprehensive understanding of what the state of aging is. So that's all from me. Thanks very much. And yeah, I think there's probably a bit of time for questions, Lee, if there are any.
Thank you, Jess. That was really insightful. Yes, Annie, Deb, I think we do have a couple of minutes for a question or two, if there are any. It's great to see on the chat that there's lots of activity going on, people making connections, sharing their contact details. So encourage you to continue to do so, and of course post any questions. Annie, Deb?
So there are a few questions. I think, as you've just said, Lee, most people are taking the opportunity to make the connections, and rightly so, via the chat facility. And I think Jess has very nicely set the scene for the rest of the event. But one key question here is, how do you think that COVID and the last 10 months of restrictions has impacted on the findings in the report?
That's a really good question. And I think the next speaker is actually going to talk specifically about COVID and aging. We have a number of resources on our website where we've looked into this. So we found that for physical activity in particular, older people are finding it much harder to be physically active than pre-pandemic. We're finding some subgroups of people are drinking more than they were pre-pandemic. We know that there are just overall inequalities have been increasing because of the pandemic, and that's something that we'd really like to see the government prioritize. We know that this age group has been particularly affected, but then we also know that inequalities have been widened, and we really need the government to prioritize prevention to help people stay healthy for longer and delay the onset of these health conditions that are also putting a lot of people at risk of COVID. And we also just need much stronger approaches to support people once individuals have started to develop health conditions or start to experience that decline. We need much better support for them to be able to manage those conditions, and much more changes in our environment, in our housing environments, our work environments, our communities, to support individuals to still be able to do those things that they value, despite any declines in health that they may have experienced.
Okay, I think if we are done with questions for Jess, we will leave it there, Jess. Thank you very much for that. Set our event up really well, and we'll move on to our next speaker. Thanks, Jess.
Thank you.
So our next speaker today is Jenny Lipiak, Professionals and Practice Manager at Age UK. So I'm hoping you're there, Jenny, able to start sharing your screen, and I'm going to hand over to you.
Hi Lee, yes, I am here. Hopefully everyone can see and hear me. I'm just getting my slides up, so I'm hoping you can also see those. Hi everyone, I'm Jenny Lipiak, like Lee said, from the Health Influencing team at Age UK. And I'm following on from Jess's presentation. I wanted to set the scene a bit about what we've been hearing about the impact of the COVID pandemic on older people's physical and mental health. And I think hopefully share some reflections and spark some thoughts about what that might mean for kind of physical activity programs and others going forward. So just to do a bit of scene setting, we know that the pandemic has disproportionately impacted older people. 1.8 million, nearly 1.8 million people over the age of 50 were advised to shield, which is about 60 to 70% of the shielding list in total. And everyone over the age of 70 has been advised since kind of March to take extra precautions. I think it's also worth noting there that many older people took on those vulnerable messages, and whether they were advised to shield because of particular conditions or not. Many people have been, through their own choice, not really leaving the house since March. The ONS publish quite frequent data about the impact of the pandemic on society. And we've just pulled out some of these recent stats, which I think is from their last week's or the week before's publication, that highlighted that 28% of people kind of aged 50 to 69 and 24% of people aged 70 and above say that exercise routine has been affected. A large proportion of people saying that access to non-COVID related healthcare is being affected, and 42% of adults aged 70 and above are reporting high levels of anxiety, which and a lot of us on here will know the real the interplay between physical and mental health and people's ability to partake in physical activity. Our research, kind of combined with things that are coming through from our helplines and from our local Age UKs, many of which I've seen on the webinar today. We did an online survey back in August, which saw a good response, and we also did representative online polling. It's worth noting that obviously both of these were online, which is restrictive to some respect, but it was the option that was available to us at the time, and the survey was also available for people to answer on behalf of older people, maybe their loved ones or people they care for, which mitigates some of that. It's also worth noting that the survey of the older people we spoke to who disclosed this information, 278 were female and 78 were male, and similar balances as well in those that were responding on behalf of an older person. More people were responding on behalf of an older female, so I just wanted to flag that. But the representative, but the polling was obviously representative. So on to kind of physical health, we know a large number of older people have seen a real decline in their physical health. We asked older people the extent to which they agree with a series of statements about how their health had changed. And as you can see from those stats, 1 in 3 people agreed they have less energy, 1 in 5 feel less steady on their feet, 1 in 4 agreed they couldn't walk as far as before, and 1 in 5 are finding it harder to remember things. Again, just going to highlight that this data was collected over the summer, and we are actually repeating this survey. The survey is currently out now, and the polling will be starting very shortly in the coming weeks. And we are expecting very much to see that, you know, as the restrictions have gone on, lockdown is back in, that these numbers will have increased. That's certainly our expectation moving forward. Jess really, in her presentation previously, really highlighted some of the inequalities that are faced by older people. And I think that question that was asked about the impact of COVID-19 on those inequalities is going to be a really interesting one going forward. I think we can draw some very good assumptions at the moment, but I think the real impact will take a bit of time to see. But we know that people that had pre-existing long-term health conditions were much more likely to report deteriorating health, and shielders most likely of all. So I think on the previous slide, it said 1 in 5 felt less steady on their feet, but amongst people with already long-term conditions, that increased to 1 in 3. And people from more disadvantaged social grades have experienced a greater decline in health than those in kind of more advantaged social grades. So you can see the difference in stats there. So 39% have less energy compared to 26% of those from most advantaged. And 22% feel less steady in their feet compared to 14% from most advantaged. We're also in the process of, once we repeat this exercise, conducting more research to understand the impact of the pandemic on older people from Black, Asian, and minority ethnic communities as well. I think it's quite hard to understate the physical deconditioning that has taken place for many older people. They're finding it harder to walk and more reliant on aids. They're finding everyday activities around the house harder to complete, and reductions in mobility are having a knock-on effect to their weight, their mood, and their energy. And I think I saw a question just now on the chat about frequency of falls, and similarly, we are anecdotally hearing an increase in the number of falls. We haven't seen that yet necessarily represented in official statistics, but certainly we're hearing similar things. And we've pulled out some quotes here, and I think the one there about, you know, mum used to catch buses to the next town and walk across town and back home on the bus, and now she's struggling to walk down to kind of the end of the path at the front of her house. I think really captures some of that deconditioning that people have seen. And the long-term impact of reduced healthcare, again, I think, you know, this was done in summer, so we're back in lockdown with numbers really high again, and constantly hearing reports about the impact that the pandemic is having on health services and their ability to support people in non-COVID related healthcare. So reduced access to appointments and treatments has left older people in pain and unable to do activities which are really important to them. We're seeing existing health conditions deteriorating while awaiting treatment, and even those that have been able to have treatment, such as this middle quote here about someone who had a hip replacement, those follow-up appointments that are really important to getting people kind of back on their feet are not happening necessarily in the same way they were before the pandemic. And the anxiety that comes from, we know there's so much evidence about the interplay between long-term conditions and mental health, and that increased anxiety about not getting treatment, not being able to manage their conditions was definitely found in our research. And following on from that, we've pulled out some of these quotes here about the impact that mobility and movement has had about people's conditions and reducing their ability to manage. People have seen their symptoms increase, their health deteriorate, and have been left in significant pain. And I think it's really hard to put into terms how significant the withdrawal and step down of healthcare has been. But if you combine that as well with other services that people use to manage their conditions and partake in physical activities, such as gyms, leisure centres, swimming pools, social groups that are focused around, physical activity, are really, contributing to that impact. And it's hard to know how many of those things are still going to be in place once the pandemic has lifted, due to kind of reduced funding and things like that. So I think that's a really important thing to think about, and something that we're certainly grappling with. And older people who struggled with ADLs, and ADLs are, we shouldn't put acronyms in the title probably, but activities of daily living. And this particular set of questions with those who already struggled with some activities of daily living, such as getting up out of bed and taking a shower or washing, that those people were already struggling but probably coping, and now finding things much harder again. So 1 in 3 people who found it hard to walk up the stairs before now find it more difficult. 2 in 5 who found it difficult to shower or wash now finding this more difficult again. Which I think is really telling. Moving on to kind of mental health, I pulled out this quote there which really captures, I think, a lot of the themes that we saw, and it really struck myself and my colleagues when the results were coming in from our research. Unsurprisingly, mental health really did come through very strongly and the impact that has had, and I think we can all relate to some of the themes coming through, but obviously we heard very specifically from older people that the pandemic had really impacted their mental health. So 1 in 3 of the people we polled agreed that they felt more anxious since the start of the pandemic, and people living with long-term health conditions or who had been shielding again were more likely to be feeling anxious, which is unsurprising, I think. And people face this real kind of double-edged sword about being too scared to leave the house, but also really struggling with the loneliness and the isolation, which I think that bottom quote there, being scared of contact with people and the isolation at the same time, really captures. And this was, again, this was done in summer where restrictions were eased a little, you could see more people, and so we're now back in the national lockdown, and I think, again, when we repeat this exercise, we'll be very much expecting to see these numbers increase, and people continuing to feel very anxious. Low mood and lack of motivation. I think this is one of the hardest slides to read and to hear about. In all honesty, there's some really hard to hear quotes, but over a third of older people agreed that they're feeling less motivated to do the things which they used to enjoy. Older people have lost pleasure in life and don't have the motivational energy to do the things they used to enjoy, and people are even kind of high levels of self-neglect are being reported. And I think that quote at the top there, which is really hard to hear, is feelings of, is this life worth living, and no joy in even the simple things in life which previously would make a day worth living, I think is really powerful. And I think when we're thinking about how we can support older people to get active, this lack of motivation will definitely need to be taken into account. And we're hearing similar, I recently spoke to one of our local Age UKs, and they're seeing similar things. So their home help type services in in recent months and weeks have seen a significant shift in the attitude of how the older people they care for and staff are now reporting that there are high levels of self-neglect, with older people telling them that they've just completely given up, and staff, they're having to support people to build resilience, to go from just day to day, which is very different to how they would have had to support people previously, and with the time of their calls and their visits have increased. This, I think, both the physical elements that I've talked about and the mental health elements kind of combine to create this real loss of confidence that we are hearing about. We asked older people how their confidence in doing kind of common activities had changed since the start of lockdown. And 1 in 5 feel less confident going for short walks outside. 1 in 5 feel less confident leaving the house by themselves. And nearly half feel less confident going to a hospital appointment. 2/5 feel less confident going to a GP surgery. And I think this quote, again, that we pulled out just really highlights some of that. This was submitted by someone who was responding on behalf of another person. And it's sad to see. She said it was sad to see how much lockdown has drained her confidence and gone from someone who attended regular groups out daily to someone who was scared to go over her doorstep. Complete lack of confidence in their ability to cope with day-to-day tasks and everyday living. Now, as I said, and I'll repeat again, we are repeating this exercise. You can see our full report on our website and from this research. And again, we'll publish an kind of updated one, but I think there is definitely evidence to suggest that this lack of confidence is down to obviously not wanting to catch coronavirus, certainly. And so, there's arguments to say, well, once the risks are much lower and hopefully that isn't too far in the distant future, people may feel more confident to go outside. And I think that's definitely true for some people. But I think it's really worth highlighting that for a lot of people, if coronavirus was gone tomorrow and restrictions were lifted, that lack of confidence would still very much be present. And the rebuilding picture looks very different for a number of the people we support. That snapping back to normal life is just not going to be an option due to some of the things we've talked about today. And this isn't just it's really personal for everyone, not just those who have suffered as a consequence of either catching coronavirus, although we know that long COVID is definitely a problem, and there are of course people dealing with kind of the long-term health implications of actually having COVID, but the impact of the restrictions that have come due to COVID, I think, are the things that are going to have much wider implications for a much longer period of time. And I think that's the end of my presentation. So if there are any questions, or if you've got time for I don't think I'm too over time, so hopefully we've got some time for some questions.
Thank you, Jenny. No, we do have time for a couple of questions, so well done on keeping to time. And thanks for painting that rather sad picture of the real impact of the pandemic on this group of people. Let's hope that the inability to move so much and the clear impact of moving less is having will help us to galvanise and really make the case for the importance of moving more, moving forwards. Deborah, are there any questions coming in?
Yes, Lee, there's a question from Sarah. Did your research look into suggestions from its respondents to improve some of those feelings of anxiety, low mood and lack of motivation? And what is it that would help them to cope with those feelings?
Our research didn't specifically ask that question, but obviously that is something that we at Age UK are thinking about all the time. And I think I've seen a couple of comments from people in the chat about things that they are doing to support older people during this time. And there are definite positive examples of what people have been able to take part in, such as, online activity sessions and things like that. I think I think it's a really important question that we need to be asking older people what support they need to be able to come out of lockdown and or to, once restrictions are lifted. And we don't have all the answers yet, and I don't think older people themselves have all the answers for themselves, but certainly perhaps things like, especially when it comes to physical activity, ensuring that people are aware of what services are coming back and what making people clear of how it's safe for them and what support is available to enable them to even if it's just a transportation issue, or get to those spaces and get to those places that they did used to enjoy and can bring back to their lives. And but yeah, I think it's something that we are certainly going to be looking into. And people did share with us during our research some of the things that they've managed to kind of hold on to. But I think, yeah, that is the big question of the moment, I think, and one that we are certainly considering, but we didn't cover it in this research.
And Jenny, you mentioned future research. What are the timescales for the future research, and when can we expect any findings from that research to be published?
Yeah, that's a really good question. So like I said, the survey is currently out at the moment, and I'd be very happy to share the link to that so that people can put out through their networks as well. I imagine, I don't know the exact timescales on when we're closing that, but it will be in the coming weeks. And the polling, like I say, I believe is starting next week, and we'll be doing for 2 weeks. So I imagine by kind of end of February, some of these things slip or move sometimes depending on, but we will have published kind of the latest of that research, and obviously happy to share that when we'll be publishing it on our website and things for when that comes out.
Lovely, thanks Jenny. Back to you, Lee.
Thank you, Deborah, and thanks again, Jenny, for that illuminating presentation. Really interesting, and again, a great starting point for us to build on our conversations today. Everybody, we're now going to go into a short break. No prizes for guessing what I'm going to encourage you to do during that break, and that's of course to move, stretch. The sun's actually come out here, so possibly even get outside and get some fresh air in the next few minutes. We do though need to start promptly at 11 o'clock to keep to our schedule. So if you could be back just before 11, that would really be appreciated. But quick 10-minute break now to get some quick exercise, stretches, and hopefully some fresh air. See you shortly. Hi everyone, we'll start again in 1 minute. Okay, welcome back everybody. Lee Mason back here. I hope you managed to get some movement in during that brief break. We're going to move on now to the next part of the session and talk more specifically about the Live Longer Better programme of work, the science and evidence base behind the programme. And really our next speaker is the inspiration behind Live Longer Better, Samuel Gray from Optimal Aging. I'm sure many, if not all of you, know of Samuel and his long-standing work and reputation in this area. Samuel, are you with us and are you ready to go?
Deborah, can you let me start the video? There, how's that? Can you hear me, Lee?
Yeah, all good, Mule.
Good.
Off you go. Thank you.
Well, we've heard about what is often portrayed as a tidal wave of the doubling in the number of people aged over 80. But the fact of the life is that we can do a great deal about this. And terrific work's been done by the organizations we've heard from. And I'm going to just summarize the science and the evidence based for living longer, better. Next, please, Annie. So we need a revolution, and you guys are the revolutionaries. And I particularly see Age UK and the active partnerships at local levels leading the revolution. Obviously, we need to get the NHS on board and local authorities. And there's other very good organizations like the universities locally and the University of Third Age. But the U2 organizations are of vital importance. The culture is there and the passion is there. So the revolution, what form is that revolution? Well, it's a revolution about knowledge. And as we say, knowledge is the elixir of life. It's been discovered and it's consumed through lifelong learning and not out of a bottle. And we develop a single system and networks. And as I say, I see Age UK and the active partnerships as the leaders in these network developments. And we need a cultural revolution. Next, please, Annie. But let me start with the sort of pitch I give if you ask me to speak to a local bridge club or bowls club or mosque. So, or to your mum or dad or grandparents. So let me start with this. So I start saying, ladies and gentlemen, there are only two phases in life, a phase of growth and development, a turning point, and from then on, it's downhill all the way. But the good news is, next please, that aging by itself is not a cause of major problems until the 90s. But it does affect two things, the maximum level of ability and resilience. Now, what do we mean by the word resilience? Well, let's have a look at the next slide, please, Annie. The maximum level of ability is affected, so people's maximum heart rate is reduced, but there's still the record for people cycling 25 miles is still in an hour in the people aged 80. So aging doesn't have a big effect, but this resilience is a problem. And it means we're less able to cope with challenges, whether the challenge is a trip or stumble, or a change in environmental temperature, or lockdown. And loss of resilience means that we are more affected by these challenges, recovery is slower and may not be complete. But that's the effect of aging. But as I emphasize, aging by itself is not a cause of major problems until the late 90s. You need a bit of luck to avoid the problems we can prevent, like Parkinson's or rheumatoid arthritis. But there are three other processes that we need to tackle. Next, please. And the first of these is loss of fitness. Interestingly, the active partnerships actually prefer to use the term resilience than fitness, because fitness is so associated with young people in leotards. Now, the turning point for many people occurs about the age of 22, when they get the first job, a sitting job, a job with a computer screen, and of course, they've got a television and computer at home. That's the shape of modern environment in which we live. But what happens is, from then on, and I've had 50 years of sitting in meetings, I'm standing now, but if I had 50 years of sitting in meetings, sitting in cars, looking at screens, a fitness gap opens up between the best possible rate of decline and the actual rate of decline. Next, please. Now, what is fitness? Well, there are two aspects of it. One is fitness affects the maximum level of ability. But secondly, if I asked you all to go and run for a mile, I'd have a much better idea who is fit, because the people who are more fit are not so disturbed and recover more quickly. They've got more resilience. So you see, those two features, loss of maximum ability and loss of resilience, are exactly the same as the key features of aging, which is why the medical profession have confused these two processes until very, very recently. But they're now getting the message. Next, please. Well, the good news is that at any age, the fitness gap can be narrowed as a result of training, of something a bit more formal. Now, that may just be 30 minutes a day of brisk walking, or 10 minutes a day of brisk walking, or 2 minutes of brisk walking, repeated. It looks as though we should aim for 30 minutes a day of brisk walking, and that helps us develop stamina. But there are 3 other S's for fitness: strength, suppleness, and skill. So what we're recommending is a daily dozen, 12 minutes on strength, suppleness, and skill, and 30 minutes on walking briskly. That means walking just at the level at which you can sense a change in your breathing. And that's called exercise of medium intensity. For people who are homebound, of course, this is a major issue. And we're also very interested in the use of exercise bikes. And there's a new type of treadmill that doesn't actually move. But I'd like to see 500,000 people walking at home using this new treadmill, or 500,000 people cycling at home. Again, just to get that pulse up a little bit. I should say the daily dozen becomes 14 minutes in the 80s and 15 minutes in the 90s, because remember, the effects of the aging process are to reduce resilience. So inactivity becomes more important every year. Next, please. So what we see and what we're doing now, and you people are the leaders of the revolution. We've had a year of deconditioning, and we now need to start a year of reconditioning. And the medical profession introduced the term deconditioning for the loss of ability that occurred when people were on a hospital ward, tucked up nicely, but not doing anything. And that is equally relevant to life at home. But I think what we should do is not only tackle the effects of deconditioning, we should help people now develop a health improvement plan. Liberation after vaccination, so that when they finish up late summer, they'd be even more able than they were before lockdown. So that's the plan. Next, please. Now, the second thing that happens is the onset of disease. And there's no doubt that disease increases the loss of the best possible level of ability. So I had a heart attack and a stent about 7 years ago. So I lost a chunk of heart muscle. So my heart can't do as much as it did before. Next, please. But what we see is that after the onset of disease, the fitness gap often gets wider faster. And the reason for that is partly the disease, but more important is the attitudes of other people. So the son says, oh, my mum's struggling to get to the shops, so I'll send in Ocado deliveries. Completely the wrong thing to do. That son is probably also a member of a gym where he's paying money for training, but his mum's struggling to the shops, encouraging her, supporting her, helping her, keeping going, even though it's a little more difficult. It's of vital importance. And the good news is to keep above the line, is what we call the line, below which the person can't get to the toilet in time. Then at any age, and no matter how many long-term conditions you've got, you can close the fitness gap. And that's now called exercise therapy. And we're working with the NHS. This will become an automatic prescription along with every drug prescription. Next, please. But of course, the third factor is negative thinking. Loss of fitness, disease complicated by accelerated loss of fitness, and negative thinking. And that's what we have to tackle. And you are the key people. Next, please. Here's the agenda that's happening at the moment. These are the 4 things that happen and interrelate. This is what the science tells us. So what are we going to do next? Well, we have to be clear what our aim is. And the first aim is to increase health span. I don't meet people very keen to live to 118 or 106 or even 98. That's not the issue. The issue is health span. closing that gap, closing that period of time when there's a gap between ability and action, the gap of multimorbidity. And we know we can do that. The second aim, shown next, please, Annie. The second aim is to help people drop a decade. And this shows that the above average person of any age, say 74 here, is the same as the average person 10 years younger. So I'm 76, with a bit of luck, I'll be part of the 86-year-olds in 10 years' time. But our aim should be to help people who are 86 now become as fit as the average 76-year-old. And we know it can be done. So drop a decade is a second aim. And the third aim, please, next, Annie. The third aim is to help people recover the loss of physical ability and the mental stability they lost in lockdown. And apologies for the typing. And use the euphoria of vaccination to stimulate and support people to transform their beliefs and their plans for the future, to get people to think ahead. Next, please. So, based on the evidence, I'm taking into account the pressures of deprivation, which bring problems on at least 10 years early. We can carry on with the traditional public health message, Mediterranean diet, be careful about agenda. But there's a new agenda. Increase physical, cognitive, and emotional activity. Every year, do a little bit more, and every diagnosis you get, do even more. Next, please. Very interestingly now, we know that the risk of dementia can be reduced by about 40%. And there are 3 steps to that. One is to protect your brain tissue. And there's some of the measures here I've outlined. And this is all based on the Lancet Commission on dementia. It's absolutely evidence-based. Secondly, keep the blood supply flowing to prevent vascular dementia, because vascular dementia is probably about as common as Alzheimer's, which we can do nothing about at the moment. So research is very important in Alzheimer's, but we need to think of the preventability of dementia. And then the third and most interesting, really, it's now clear that staying intellectually active and involved, for example, being a volunteer, is probably the best thing you can do to reduce your risk of dementia. Being challenged, being forced to learn new ways of doing things and adapting to others. Next, please. So how are we going to do this? Firstly, we've been working with 17 active partnerships, and we'd like all the active partnerships involved, and that's our plan. But the key thing would be to get Age UK's involved as well. And here are the objectives. A system is a set of activities with a common set of objectives. And this is the way we've run a lot of for example, all the screening programs in the UK. So you have to focus on the objectives. And as you can see here, these objectives are bold. And there's one focusing on physical ability and resilience, but also to think about how do we minimize and mitigate the effects of deprivation. And one we're working on at the moment in several parts of the country, how do you reduce the risk of a bad death? Because inappropriate admission to hospital and intensive care is not a good way to go. If we need to think of ways of helping people think ahead. So these are the objectives of the system. Now, the system, next please, Annie. Systems are delivered by networks. And I'm a veteran of, I think, 27 reorganizations of the NHS, most of which have made no difference at all. And the system needs to be delivered by a network. And a good basis for the network, it might be at the sort of county level, Lancashire, but it might be at a more local level. And in Lancashire, we're working, there's probably going to be 5 networks in Lancashire, often related to the traditional healthcare networks linked to the local hospitals. So developing networks. But I say again, local Age UK and local active partnerships are key leaders, and I can help bring along the NHS, and we can also get local authorities involved. But the passion and the drive for the revolution has to come from Age UK and the partnerships. Next, please, Annie. And networks give leadership. And the distinguishing thing about leadership as opposed to management is that leadership changes culture. And we need to change how people think. So our estimate is there's about 1,000 people per million population who need to think in a different way. And the networks will reach them. These are wardens of shelter housing, practice nurses, GPs, pharmacy assistants, housing managers, volunteers. They do think a different way. And here are some of the resources that we've got available. And we need a new language to change culture. Next, please, Annie. We need to do with the word care, which since 1948 has been doing things for people. We need to do away with that and move on to another language, enabling, supporting, coaching. But enabling is probably quite a good word. And the fact that people have never used it before is an advantage when you're getting changing the way people think. Next, please, Annie. So here's the learning program. So here's a program we're going to deliver to older people, and probably through GP information systems. They need to think in a different way. Next, please, Annie. And people that you're working with, there's probably about 1,000 per million population. They need to understand what we're saying to the older people, but they need to think a bit more in depth about what it means for their daily job. Next, please. And now the leadership. That is you people who've joined this revolution today. And it's great to have equal numbers of active partnerships in Age UK. We need to have this new culture. So you are the leadership. You will lead the cultural revolution, and we will be very pleased to support and enable that. Next, please, Annie. Here's the new agenda. Understand aging, regain fitness, prevent and tackle disease, and think positive. Thank you. And here is the last slide. 2021, it's the year of reconditioning. Thanks, Annie, that's it.
Thank you, Samir. Samir, can you put your video on just for a second, if you're able to? We've got a minute or two just for...
It says my host has stopped it.
Oh.
I'm sure it's me. It's always me when things go wrong.
Not a problem then.
Well,
Deborah,
if you've ever seen George Clooney at 30, that's exactly what I look like.
Yeah, I can vouch for that.
Yeah.
Deborah, Annie, a couple of quick questions. Samir?
Yes, Lee, we've got a question from Kat, and she's very interested, Muir, to hear about the prescribing walking with each drug prescription. Yes. Is there more you can tell us about that?
Yeah, this is the jargon is social prescribing, and that could be joining an art class or joining a voluntary group. I'm a great believer in encouraging people to volunteer, for example, to help with reading in a primary school. So it doesn't only need to be an activity prescription, but we are certainly looking at activity prescriptions. And this would mean that, supposing, Deborah, you were diagnosed as having atrial fibrillation, you would automatically, even if the GP didn't remember, you'd get a message if you're online, of course, and that's digital inclusion is very important, but you get a message in a week saying, Deborah, I'm sorry, we didn't have time to talk very much about atrial fibrillation, but here are some interviews from the Richmond Group charity of people who've got atrial fibrillation. Here's an exercise program you've got. And here are 3 centers near you where there is a trainer who understands cardiac rehabilitation. And you would get that, and your pharmacist would know when you went in that you've been given an exercise prescription. And you say, oh, yeah, and how's the activity going? My husband's just done the couch to 5K, and I mean, he was a bit of a pain in the neck, but it's transformed him completely. So this would be something that would become a routine part of clinical practice. And I say, we didn't even be very good if the GP can say, oh, Deborah, this is very important. But even without that, we'll be reaching people with the voice of other people.
Lovely. Thanks a lot, Muir. Back to you, Lee.
Thank you, Deborah. And thank you, Muir. We're going to move on because of our timeline today, but that was really inspirational. Your passion comes over. I know you're in this for the long haul.
Yes, yes.
And I'm sure lots of people have got lots of other questions. So please do keep those coming in the chat. If we can't get to them today,
We'll answer everything. Yeah.
Back to you. Thank you. Right, let's move on then. Our next speakers are Nicola and Beth from Greater Manchester. I think it's Nicola starting, but correct me if I'm wrong, and I'm going to hand over to you.
Thanks, Lee. I am. I'm going to just do the dreaded screen sharing bits, and hopefully that will go seamlessly. Lee, can I just check you are seeing the slides?
Yeah, that's perfect, Nicola. Can you turn your video on as well?
Yeah, yes. Sorry, I'm slightly struggling with that now. I can't find the Zoom controls.
Don't worry if it's a problem, Nicola. We've got your.
I'll leave it off for now,
slide.
and then while Beth's speaking, I'll try and work out how to. Actually, now I've found it. It's fine. There we go.
That's it. We've got you.
Brilliant. Hi everybody. I'm Nicola Waterworth. I am the Greater Manchester Partnership Manager for the Centre for Ageing Better. I'm based in the Greater Manchester Combined Authority with the Ageing Hub as part of our partnership with Greater Manchester. And I'm here today really talking about the work of the Ageing Hub. So Beth and I want to talk you through the example of Greater Manchester, the work that we do to support a community around ageing and age-friendly agendas. We do that more broadly than just being active, but Beth's going to talk to some of the work that we particularly, she's been leading on around the active agenda. And we're going to talk through some of the impact that we feel that has and the benefits and challenges we face. And we will try and get through that in time to have some questions. Please bear with us because we've had limited rehearsal of the passing between each other on this one. So I'll just start off. I'm just going to give some background around the Greater Manchester and the work that we're doing in terms of the Ageing Hub. So Greater Manchester, we're operating in Greater Manchester on the combined authority footprint, and I appreciate that's not necessarily the footprint or the kind of structures and arrangements that is directly replicable in the other areas that people on the call here are covering. But what we're hoping to do is pull out some elements that we think are most helpful in terms of thinking about networking. I think it's also quite important when we talk about Greater Manchester and the work on ageing that we recognise the work that Manchester City Council did for a long time over the last 20 years around age-friendly work and starting originally the UK's age-friendly communities network, something Ageing Better now coordinate, and there are 42 members of that network. And I think that's, just mention that, as I think that's another key kind of place to plug into those age-friendly communities. So age-friendly, the ageing agenda is one of 10 priorities in the Greater Manchester strategy. There's a supporting architecture around that within the combined authority system, a partnership, a political portfolio lead, a lead chief executive. GM works closely with the 10 local authorities that make up GM and their district level plans around ageing. Greater Manchester was recognised as the first age-friendly city region by WHO. I'm really pleased that's no longer the only city region in the UK to be recognised in that way. And there's a small core team at the Combined Authority that support this work on the age-friendly strategy. And then what we talk about, and a lot of what we're going to be talking about today, is working with a wider team of GM agencies and partners to mobilise and have that kind of system level impact around ageing. And we at the Centre for Ageing Better have been in a strategic partnership with GMCA since 2016. So convening and growing this age-friendly community or network, as I think Maura's just talked about it, as is a really key priority for the Aging Hub. We've just actually done a review with that wider team about how and why we do that, and what you see on the slide here, really the kind of the terms of reference about the purpose of why that network's coming together. I think a number of those echo things that we've heard already about today around having shared purpose and narrative understanding. We're increasingly turning our attention, as we will in this presentation, to understanding how we deliver systems level change and the impact that has and how we talk about that. And the voice and experience of older people, incredibly important in that work, as well as the evidence base. The partnership in Greater Manchester, as was already talked about, all of the local authorities are represented on that, but also a wide range of GM agencies. So Beth, obviously with Greater Sport, GM Active, who are the leisure provider network, are also represented on that partnership. The fire service, police, the Greater Manchester Health and Social Care Partnership, we have housing associations, all of the people you'd expect, and of course, obviously also the voluntary and community sector. So we have a lead Age UK representative, but also we regularly have other voluntary sector and other Age UK members coming to our meetings and events. So it's a very wide-ranging partnership and very open. And actually, the other group that I haven't mentioned is Greater Manchester, particularly lucky to have quite a number of research institutes within the 3 main universities in Manchester. So we also have quite a lot of research and academic members regularly coming to our events and meetings as well, being part of the network. As I said, we had recently looked at the value of this community and bringing it together. And here's the kind of quotes and we did a brief kind of survey work about what people really valued about the network. Because of the pandemic, we went online, obviously, as everybody did, and actually reflecting on that, we really feel that strengthened the work that we've been doing in Greater Manchester. Coming together across the geography that is Greater Manchester in a physical sense was actually quite hard for us, and the meetings were fairly infrequent, and it was very difficult to coordinate. We did a very responsive let's meet weekly very early on in March, when we were just trying to understand what the impact of lockdown was, what we should be doing. And actually that we maintained that weekly online meeting throughout last year. We're just shifting now to a fortnightly meeting, but people have really valued the ability to seek support, to connect with other people across the agenda, to share knowledge. We've got lots of examples how that coming together weekly managed to escalate some immediate responses for older people during the pandemic. So, you know, Beth, for example, I think had a web page with suitable moving at home links on it within about a week of lockdown and circulated to that group, but also very real and specific issues for older people. We've had a range of scams associated with lockdown and restrictions that we've managed to kind of gather intelligence on and circulate, issues with transport. And I think there's been some reference already today around digital exclusion. And that's been a really, sharing intelligence around that has been really key. And when we talk about Keeping Well This Winter campaign, how we reach I think it's about 160,000 older people over 65s in GM with no access to the internet, with messages of how to stay active and a whole host of other messages, was really key in part of the work on that campaign. So we actually think, as I said, the pandemic has strengthened a lot of the work that GM is doing around connecting, sharing intelligence, and being those system leaders for GM in aging. So I'm going to pass seamlessly over to Beth now, who's going to talk a little bit about some of the specific active work that we've been doing. Beth, are you able to unmute?
You froze then as he was transferring over, so I was just waiting. Hi, yeah, thanks everyone. So I'm Beth. I'm the active aging lead at Greater Sport, in partnership with Greater Manchester Moving, and I'm just going to talk through some examples of the successes we've had across the last 12 months, particularly focused on the COVID response due to having the network and being supported by the Aging Hub and the wider team. So just to name a few, as Nicola alluded to, we managed to pull together a public narrative around, instead of the GM moving, original narrative to keep GM moving, and we adapted our webpage, and we had leaflets for those who were digitally excluded around how we could support people to stay active during the lockdown. And through the partnership, we were able to connect with academics who could support us with supplying the best evidence-based and safe practice for exercise in the home, particularly for those with long-term health conditions. Another example is, as we have the partnership, we were able to connect with health and social care and look to start some work around GM Strength and Balance Falls Prevention Collaborative to bring together both clinical pathways and connect community provision. We've got some really good examples of where it works really effectively in some areas of GM, and we want to share that practice and see whether we can get a joined up approach from GM. And this was sort of escalated due to the evidence we were receiving from academics around obviously the increased risk of falls due to deconditioning and what we would see as we start to come out of this pandemic. Another example was we developed an NHS and adult social care physical activity working group, both to respond to COVID-19 and mobilise our Keeping Well This Winter campaign, but also look at what evidence-based practice we already had, such as the Keep On Keep Up Falls Prevention Strength and Balance app, and how we could roll that across GM. So we're currently doing a pilot in Tameside and care homes to look at the impact of that and then scale that. And then we've also got what sort of longer term vision in terms of, as we come out the pandemic, how we continue that conversation, particularly focusing on influencing the CQC to look at integrating physical activity within standards to make sure that physical activity is the norm across care settings in GM. We've also aligned our active ageing work with GM Moving and Greater Sport within our strategy refresh. And we've taken that to the GM Aging Hub and the wider network for our wider partners to feed in and support us with the development of that. And then finally, another example was based on the impact of lockdown, we decided to focus our efforts in the over 50s and active travel, which was already on our agenda as a priority area, but this sort of rapidly escalated as we saw much quieter streets, the impact of the government guidance around physical activity and your walking every day, and we saw more people out on bikes. So it's an area that we need to focus our efforts. So we pulled together an active travel and over 50 steering group from a range of partners within the network, and started to pull together a bit of an evidence review of what we already have, what data we already had, and where the gaps might be and how we might want to focus some of that work. So they're just some examples of how having the Aging Hub network and the wider network enables us to rapidly move some of this work forward. If you are right to just move on, Nicola. And as I mentioned, the Keeping Well campaign, this is probably our biggest example in terms of having a whole system campaign. So it was driven and coordinated by the Aging Hub, and all our partners were able to feed in based on the expertise within their areas. So, for example, on the right-hand side of the screen, we've got our Keeping Well This Winter booklet, which is a second version of our Keeping Well at Home booklet, which we produced way back last year. We were able, due to our connection with the universities, to do a rapid evidence review and some evaluation on that, which is how we adapted the second version in terms of people wanting to see more information on scams and fraud, fire safety, those kind of things. So in there we've got a wide range of guidance on money matters, physical activity, strength and balance, falls guidance in the home, fire safety, how to keep warm, etc. And that's been distributed across GM, through our partners. In the middle of screen, as the campaign was
focused towards the workforce predominantly in terms of how we could support older people and how we would have a conversation and the questions we might ask people about how they're keeping well this winter. So how are you doing today? What's on the menu tonight? Those kind of questions that you can find out a lot about a person if you ask. And then finally, on the left-hand side of the screen, we're very lucky in GM to have an organisation called Talking About My Generation, who bring together a range of older people from across GM who deliver on a wide range of podcasts and website information, and they produced a video on the views of older people, and it was designed with them for older people, which is our core focus. And I think just one more slide, Nicola. One thing we're really keen on is trying to measure impact, and particularly trying to measure impact as we go rather than evaluating at the end of a campaign. So through our partnership, our GM Moving team and evaluation team shared the Healthy Systems Framework, which we mapped the Keeping Well This Winter campaign against. So this is just one example of the element of the table which we've pulled together around what matters and how the work and routes change. And then we've identified indicators and observations for this, where we've got evidence from the campaign, and then the evidence we've gathered. So I don't know if there's anything you want to add there, Nicola, as you populated this table.
Thanks, Beth. I think I'd just say that what we're trying to do more consciously and maybe systematically, or that might be the wrong word, with the Keeping Well This Winter campaign is really think about impact in quite a responsive way, so we can improve the distribution of this campaign now and in the next few months. So we come together quite often with the steering group to look at what maybe is working in one area to try and share it with another, but also trying to think about how that can inform the broader kind of systems change, who we're engaging, who we might not be. So if I'll just briefly, because I'm conscious of time, share, this is a kind of initial attempt. It's an unfinished map of our engagement around this Keeping Well This Winter campaign. So the white boxes are those people who are actually been engaged in our steering group, have contributed content, messages to that kind of campaign work, and then the blue are places that we know we've reached to. We really feel that this focusing like this has supported us to reach out to a much wider network. I think you'll see there some of the themes that have already come up this morning around social prescribing networks, but also vaccination. So we have managed to get the booklets into a number of vaccination sites, and then when that's been achieved in one place, it's potentially encouraged some others as well. But that network reaches from employment providers, citizens advice, through to kind of quite a lot of health elements of the health system as well. So we're trying to more consciously think about that impact and capture examples of practice, which I guess brings us just on to some of the reflections that Beth and I wanted to share about positives and challenges around the network. I think we're very lucky in GM to have this strategic focus at the combined authority level and some of the capacity and resource to bring people together in order to join up dots and support people to be system leaders. We think it's absolutely essential that we have older people's voices and experience at the core of what we're doing there, that the Aging Hub and the network is sharing those voices with other people to create influence. It's not without challenges, as I'm sure you're all kind of aware of these. Growing it, making sure we're speaking to people who kind of aren't in the club, so to speak, is a constant thing we need to be aware of. There are lots of directions to look when you're working in such a wide-ranging partnership. The impact of COVID is very real on people we're working with and the services and responses and capacity, as I'm sure you're all aware. And I think this point that we're trying to share with you here now is really understanding more about how as a network we're adding value and delivering impact is something that we're developing, but trying to do more of. And I think as someone, I've worked a lot of partnerships over my career in a lot of different areas of public sector. And kind of the network, the bringing together of practitioners, the sharing opportunities to learn together is really, I think, where we're making a lot of the difference in GM. Beth, have you got any other concluding comments you wanted to add?
No, I think you've covered everything there, and I think we're running out of time, so we might want to pass over.
Can I just briefly share our pictures from, because one of the things we did a lot about images and representations, we wanted to share some active cycling pictures that we found at the end there.
That's great. Thank you, Nicola, and thank you, Beth. That was really good, and clearly the importance of partnership work in collaboration and the system change approach comes through strongly through those examples. Time is against us, so no time for questions now, but please pop them in the chat and we'll try and respond to them later. But because of time, and we've still got 2 speakers to come in this last 15 minutes or so, I'm going to move us straight on. Casey, if you want to start sharing your screen. Our next speaker is Casey Dunlap, who's the Active Medicine Programme Manager. Over to you, Casey.
Thank you. I'm just sharing my screen now. Hopefully everyone can see that okay.
Yeah, that's all good, Casey.
Great. So hi everyone, I'm Casey Dunlop. I'm the Programme Manager that's looking after the Active Medicine Programme, and that runs across the 3 active partnerships in Thames Valley. So that's Get Berkshire Active, LEAP and Active Oxfordshire. And for the next 10 minutes or so, I'll just give you a whistle-stop tour of what we've been doing on the project so far. And I'll tell you a little bit about the background, how we've adapted to COVID, what we've achieved so far, and then also some key learnings. If there are any questions, please feel free to put them in the chat, and I can answer them after the webinar is finished. So a bit of background, just to set the scene. The Active Medicine Programme came from Sport England's Workforce Innovation Fund, and it was a collaborative bid between those 3 active partnerships, as well as the Bob ICS prevention group. And Bob is the footprint for the integrated care system here. So that's Bucks Ox and Berkshire West. And it started back in October 2019 with funding for 2 years. The overarching mission of the programme was really to increase physical activity levels in people who are least active, so really broad scope, and that was through increasing how important physical activity was for healthcare professionals in their roles, and to also increase the confidence that they had to promote and discuss physical activity. So that was kind of the main objective. And as an innovation project, we were given a fairly blank page in terms of who we focused on and what training we used, to be decided once we started. So in terms of timelines, because of that blank piece of paper, we spent the first 6 months doing a scoping and planning phase, and we mapped out our stakeholders. We really tried to figure out exactly what was happening on the ground in terms of training that was available, both being delivered locally as well as all of the different e-learning packages, and what the priorities were for our stakeholders, where physical activity fitted in. And from that insight, designed a programme that had 2 strands. One, to promote what was already there, increasing connections within the system, acknowledging that there was lots of great work already happening, like moving medicine, like making every contact count, and then deliver where there were gaps. So the training that we had planned, the majority was a motivational interviewing course with a physical activity focus. Some of those were being delivered going to be delivered jointly with the CCG, and then some were delivered through Get Berkshire Active, depending on what capacity was on the ground. And then COVID happened. We cancelled all of our face-to-face trainings. We didn't want to be contacting healthcare staff because they were dealing with the emergency, even with online training. And that that covered both frontline and our strategic level who were needing to deal with that emergency response. So we really needed to have a rethink about what we could do. So what did emerge from those first few months of the pandemic was the importance of those wider roles in the community that was supporting those that were most vulnerable, isolated, older adults, and those roles were the community hubs, the volunteers, the charity sector organisations. And at the same time, we were noticing that the importance of physical activity was growing in terms of being connected with how it could improve mood and anxiety and impact depression, which were all becoming really key factors to focus on while people were in lockdown. And the gap that emerged was that we needed to upskill all of those frontline facing roles, not just healthcare professionals that had the opportunity to have those brief conversations about physical activity with the people that they were meeting every day. And any training that we did deliver, we knew had to be very short. It could only be online. It really needed to be engaging to capture those audiences, adaptable so that it could be tailored and hyper-local because of how things were shifting. And the components that we identified that needed to be part of any training were the ones on the screen. And as people have mentioned in the webinar today, the barriers we really needed to talk about motivation and the real barriers that people were facing, and how we might help through our conversations, through encouraging and motivating. So from all of that, we decided to create a 1 hour virtual helping people stay physically active training that was delivered by the Active Partnerships. It was aimed at a non-clinical audience, so without health or physical activity backgrounds, and it combined both the physical activity and the behaviour change elements with a making every contact count approach. And we started to pilot those from late June, July, August, we were piloting those. At the same time, as soon as the PHE physical activity and clinical care training, which is a standard national training, as soon as it went online in September, we started to deliver open sessions so that, across the whole of Thames Valley. So they were open to any registered healthcare professionals, and we went out far and wide with our promotion, so including roles like pharmacists. We went out to care homes, paramedics as well, so really trying to include everyone. And we also adapted the motivational interviewing training that we did have to be in a modular format to fit with that online delivery. And to bring together all of the great opportunities that already existed, we created online learning hubs for each of our active partnerships, which brought together not only the virtual training, but also the e-learning packages, the toolkits, and all of the great campaigns, so that they were all in one place for people, for the workforces to be able to find. In terms of progress, and what has been achieved so far, in terms of numbers, so far 373 people working in those health and social care roles have been trained across Bucks, and Berkshire, and that is a combination through the combination of training. So that includes healthcare workers, so your doctors, your nurses, pharmacists, as well as social prescribers. They've been a key focus, and then more than 150 of frontline roles, so roles that are in charity sector and also council as well. And some of those organisations have included Age Uk, Mind, Adult Social Care. The feedback that we've been getting from our training is that by the end of our trainings, participants are feeling that physical activity is more important, and that they feel more confident to have those conversations. And they're also reporting that they feel more knowledgeable about benefits, guidelines and signposting. I just wanted to give a couple of quotes from the feedback forms that we've got. So these three are from our helping people stay active training. So I'll just let you read through those ones. And then that last one is from the PHE training as well. For key takeaways, what we've really learned on the project so far is that we really needed to work collaboratively as a team across organisations. So what has been done so far is only possible because we've worked with PHE, Health Education England's training hubs, as well as the organisations on the ground that are releasing staff for training, that are promoting our trainings as well. We've needed to consider the whole workforce with multiple options, be flexible and adaptable, and really think about all the time physical activity being a tool for current priorities. And I think we're short in time, but that's those are some of the wider impacts that we're seeing as part of the programme as well. Okay.
Thank you, Casey. Really great examples, some clearly great work going on there, and perhaps more importantly, some great learning from your work over the last 12 months or so. We don't have time for questions now, but again, pop them in the chat and we'll ask Casey to respond to them later. And we're going to move on quickly to our last speaker so that we can hopefully finish on time, which is Caroline from Age Uk Milton Keynes. Caroline, if you're able to share your screen on your video, that would be great.
Hello everyone, I'm Caroline from Age Uk Milton Keynes, and I'm just going to quickly fly through a bit of an overview about our walking befriending service. So basically, Age Uk Milton Keynes is a local and independent charity. We support about 10,000 older people from the age of 55 every year. Our mission is basically to improve the well-being and quality of life for all older people in Milton Keynes. We're called brand partners because we're part of the Age UK network. There's about 130 different Age UKs working in different localities. All Age UKs offer different services that are appropriate to the needs of their community, basically. So I'll just mention about the start of the befriending project. So it's funded by Sport England. We responded to a call out from Sport England through their active ageing programme that was basically saying that they were looking for organisations that had ideas about how to get older people active, because there was a lot of focus from Sport England about kind of understanding the ways in which older people can become more active and move more, basically. And they were just asking for as like a wide range of ideas as possible, because they needed to test approaches before they look towards funding and before they look to like wider strategies. So here at Age Uk Milton Keynes, we kind of identified the befriending service as a suitable option. And that was because we'd been running befriending services for a long time. The model had always pretty much been the same. And it kind of focused on the oldest old. So people in their 80s, late 80s, 90s, people who are often either housebound or certainly inactive and a bit detached from the community. They might have been lonely, isolated, and separated from family members. So we thought that it'd be quite useful to kind of use them as a like a stepping stone for this kind of project. So like I've mentioned, the traditional client would be isolated, at risk of loneliness, or identified as being lonely. And quite often they've experienced a significant life event or stage, so such as bereavement, retirement. They might be separated from their family members in some way. So for our starting point, we chose to kind of focus in on that life event stage. We were looking for people who had been bereaved in recently bereaved and were or had been through a significant life event, such as period of ill health, etc. And as a result of all these factors, they were experiencing barriers to becoming active. We decided that walking was something that people liked. It was accessible, and they would like to do it, but there were certain barriers that they needed to overcome in order to kind of regain their confidence and to get back out again. So our focus was to start starting basically with short walks in the immediate area, in their neighborhood, kind of getting them slowly out of their house and experiencing things close to them. So we have a befriender who visits them. The befriender is trained, and yeah, they visit them at their property and they basically go on short walks in the immediate area. So like I say at the bottom, we wanted people to be moving more regularly. Increasing confidence was a massive factor for us because we recognized that these barriers had knocked people in a degree that they might have previously been active, they might have had lived very fulfilling lives, but things had happened to them and it meant that they were lacking in confidence, and the support of having somebody walking with them, giving them that reassurance and motivation was key to making this work. We also wanted them to move on to other activities. There's a very good local walking network, but we found that people were put off by joining it because the walks start at a minimum a mile long. And so people were a bit reticent to join because they felt they wouldn't be able to keep up, or that their health problems would cause them to fall back. So part of this process was to try and get people to move towards doing more in their community and just getting out the house and not being so fearful and afraid of their surroundings. So just a quick summary. So over the project, which has run for 2 years, we've supported about 76 clients. There's been quite a weighting towards female clients as we've moved through the project. So about 70% are female and about 30 male. Initially, we had more men signing up to it, but the women seem to exceed it in later stages. So we've had a very broad range of ages, from 58 to the oldest being 96 years old. They've all come to us with very particular needs and on a very individual basis. So we've had to try to address that. So each volunteer works with their client to kind of overcome their individual barriers. So we've noted that about 3/4 of the people who'd taken part had at least one long-term health condition. So for us, that was quite, it wasn't something we were expecting to be so high. And the range of conditions were from people who had had strokes, suffered with Parkinson's. There were also people who had dementia, Alzheimer's, and we also had quite a few people that had low-level mental health problems as well, such as anxiety and depression. So the range of walks was about, by the end of the project, between 20 minutes and 2.5 hours for participants. So bearing in mind, some of the most older, frailer clients came to us not walking at all. So for many of them, they hadn't left their home in the week before we took the baseline statistics. And for some people, they were only managing to walk for about 10 minutes. So through the course of the project, we've seen a massive increase in the frequency in which people are walking and the length of the walks and the amount of time as well. This is just a picture of one of our clients here using her walker in her neighborhood with her befriender. So like I said, we've always wanted to start small because we thought it would make it more achievable for people to get on board, setting kind of like a low benchmark to say start small and extend as you can. We found that some people, took the bull by the horns and were really engaged very early on, and they wanted to go out and do more very quickly. But starting small has certainly helped us capture the people who are the oldest and the frailest, and that would not be the type of person to kind of engage with physical activity. We've kept in regular communication with people. So we've taken surveys at baseline 3, 6 and 12 months to ensure we can track their progression. We've used loneliness scales, WebWebs to kind of track their well-being, as well as the short active life survey initiated by Sport England to track their activity levels specifically. We've asked the volunteer befrienders to kind of journal what's happening throughout the process. So we get feedback straight away after walks, and we're able to see about issues that have arisen, if there are any things that we as an organisation can support them with that might be aside from the physical activity side of things. And Sam, who's our coordinator, has set up opportunities for the volunteers to get together regularly. She brings them together because these volunteers are essentially lone working, so they don't normally have the support. They don't normally have somebody with them at all times. So it's a good opportunity to kind of bring them back in-house and ensure that everything's okay and we're getting regular feedback about the activities and what they're doing. Key to this role is Sam, who is our coordinator, and the matching process is so essential because we found that the most successful partnerships, the people that are walking more, the people that are walking more regularly, the people who have also been able to walk independent of their walking befriender, have had a really solid relationship. So we pay very close attention to matching the volunteer and the client. We look at locality, we look at abilities and interests, but the volunteer match to the client is very, very essential to this project. This is another picture of one of our walkers. This is a lady who actually has dementia, and on their walks they go to central locations and she takes her kite. So the volunteer is able to kind of help her along the way and be a support for her, but this lady also gets independence, and I believe this is one of the few places that she can go outside of the home, because for most of the week she is at home. So very important to the progress of the project has also been referrals. So we've worked with local organisations and groups to ensure that both client and volunteer referrals come in roughly evenly, because it's a constant matching process. You have a batch of clients, but then you also have to train volunteers and get them up and running to be allocated to the clients. So it's been very important for us to work with local organisations, the local authority. LEAP have been very supportive in promoting the service as well, just to raise awareness of what's going on in the community and what's happening with our project. We've also found that we started smack bang in the middle of winter, so it was very hard to get the service going initially. And we've often found that between March and October, November is the key walking period. So we can utilise winter for promotion, for ironing out any kinks, for ensuring like all our data and things are kept up to speed. But we do encourage people to keep walking throughout the year. And for many of the pairings, they are happy to do so. I think it's the people that are frailer and a little bit more unsteady on their feet that would prefer not to walk in the winter. So that's been very useful learning for us. Early on, we also found that people wanted to go further. So they wanted to get out of their neighbourhoods. They wanted to go to, we're quite lucky in Milton Keynes, we've got lots of green spaces, linear parks, lakes, places that are suitable locations and points of interest. So people wanted to explore, they wanted to go by the canals and the riverways and walk in places that were further than we appreciated and further than we thought that they would want to do so quickly in the project. Which kind of highlights the importance and the impacts of just being outside and what that does for your mental health and what that does when you've got a companion. It's often easier to do things when you do things in a pair, and walking is one of those things. It becomes less functional, but it becomes something that you really enjoy. And it's like a hidden way of doing exercise. You're doing exercise, but you're not really aware that you're walking as long as you're walking, or you're going as far as you are. So we found that quite interesting. And we've also seen that the walks differ. So some people are very focused, they are task focused, so they want to be able to walk to their local shop or to walk to the post office. So they use the befriending walks as an opportunity to do that. For some people, we've had people setting mini challenges. So they've walked a distance, they know their capabilities, but they're looking to extend it. They like to track their steps or see how far they're walking in distances. So they work quite closely with their volunteer to kind of plan that, and it gives them little small achievable markers to kind of achieve and then go beyond. So that's really encouraging for people that are keen to kind of track their walking that way. And then we've also got people who like the good social walks, so they go for quite long walks, and there's quite often a refreshment break, a cafe or a pub maybe, where they get the opportunity to chat to the befriender, not in the home like traditional befriending would be, but outside in the fresh air, in the open. They can talk about things that they're seeing, and it's all very, it's very social, but activity is absolutely at the heart of it. And people really have embraced that throughout the project. And this is another couple of our a befriender and a client, and they've almost been like the poster child for the whole project, because they've embraced it from the start. They're actually quite similar in age, but the client had experienced a lot of health problems and setbacks, and to the point that he was taking medication and he wasn't basically getting out the house. And this service has been an absolute transformation for him. It's given him confidence, it's given him the ability to increase his connections and have a new friendship and kind of engage with the local community in a way that he previously wasn't. So they've been a great success story for the project. Then I'll just really quickly talk about our experiences during lockdown. Obviously the service had grown to a level and there was a lot of momentum that had been built. A lot of the clients and the volunteers were like moving in positive direction. Things are increasing, the length of walks, the frequency of walks, etc. And then lockdown happened, and all over 70s and people that were clinically vulnerable were told that they had to stay in for a minimum of 12 weeks, basically. So things did grind to a halt. But what Sam did was she set up a telephone service to ensure that the befriending relationships can be maintained. And then once things started to ease, we had a few volunteers that were able to do doorstep visits. So from a safe distance, go and visit their person that they're befriending. But there is also, the guidelines also changed. And once they changed, they started to allow people to do a little bit more, and it was safe to meet outside, not in the home, but meet outside in a location. So once that happened, we started the service again. Obviously with lockdown, the third lockdown, where it's had a big impact, but we've also seen like an increase in the number of inquiries, which is really, really interesting. We've currently got 21 people who have contacted us and have been assigned a befriender, walking befriender, ready to go as soon as lockdown lifts. So that is also quite interesting, considering we would assume that people might not be ready to walk, especially, or be thinking about walking, but actually it's showing that there is a desire to get out, there's a desire to make connections with people as well. And so for our next steps, we're basically going to embed what we've been doing through the last 2 years into our existing befriending service. We have one coordinator, one point of contact, so we're able to assimilate it quite easily into the service. We are also going to engage with local services and ensure that there are exit routes for people who are now at the place where they are fit and able to do the health walks locally and other activities with local providers. We're completing our evaluation, and I'm also in the process of writing a toolkit, which will be hopefully available to share with people that are interested, other Age UKs, etc., for just hints, tips and things about setting up a service such as this. So that is it. It was a bit quick. Hope everybody got that. But if you need to get in contact, contact details are on there for myself and for Sam, who's the coordinator.
Thank you, Caroline. Thank you for getting through such a lot of material so quickly. Guys, we have run over slightly, so apologies for that, and thanks most people for sticking with us. We are going to wrap up now. Just to say thank you again to Caroline. Thank you to all the speakers, in fact, absolutely inspirational. Thank you to Samir for getting us growing and galvanising this piece of work. And thanks also to Annie and Deborah at Active Oxfordshire. We've heard about some of the real challenges that we face, but we've also heard some real inspiring work that's going on, which is really encouraging. Feels to me like we're really starting to build a movement around this work. I want to encourage you to join that movement, to continue to stay engaged with us and the work that we're doing. There's been lots of active chat in the chat function, which we will capture, and please continue to chat away and share your practice and learning. If you're not in touch with your local active partnership, I'd encourage you to get in touch with them, see what they're doing in this space and see how you can get involved. There will be a post-event survey coming out to everybody that's taken part today to get your feedback on how we might continue to involve you moving forwards. I think that's about it for now. The session has been recorded. We will circulate that and the slides or links to it next week, so please look out for that. Please do complete our post-event survey. Other than that, thank you for joining us today. Sorry we've run over slightly. Thank you for sticking with us, and we'll see you next time. Thank you.